So naturally, we can lower cholesterol by weight loss. Again, whether you do it through diet, surgery, or with medication. Other ways that you can lower cholesterol naturally is with limiting food that is high in saturated fats. Mainly cholesterol in the diet comes from what's called saturated fats that can occur in processed foods, fried foods, red meat. And then it's important for the clinician to also rule out secondary causes of high cholesterol. Excess alcohol or problems with the thyroid or other endocrine problems can cause high cholesterol as well. My name is Dr. Mahmoud Al Rifai. I'm a cardiologist at Houston Methodist. Naturally, lowering cholesterol with diet and exercise takes about 4 to 8 weeks just to start seeing some effect, but it can actually take a little bit longer, 3 to 6 months, to really start seeing the effects. Most studies will cite about 5 to 15% reduction. So I usually tell my patients around 8% lowering of cholesterol just with diet and exercise. The guidelines are very clear about this. Any patient that has a history of heart disease or stroke should be on a cholesterol medication. And then when I say cholesterol medication, it's a medication that you take for life. It's not just a few months, you wait till your cholesterol numbers get better and then you can stop it. This is a medicine that you have to commit to lifetime. So these are patients who have a history of heart disease or stroke, as called secondary prevention. There's another bigger group of patients called primary prevention patients. Those are patients who have not yet had an episode of heart disease or stroke, but who are at risk of having those in the future. Patients with diabetes, patients who have extremely high cholesterol, so LDL more than 190, because those patients, we think they may have some genetic causes to high cholesterol. Those are also patients that need to be on cholesterol. But it is a nuanced discussion with the patient and the clinician. It involves estimating someone's risk using risk calculators. Commonly, low risk will avoid giving cholesterol medication, but intermediate to high definitely favors the decision to be on a statin or other cholesterol medications. Besides these risk calculators, we also look at family history, rheumatoid arthritis, these inflammatory conditions. Even in pregnancy, preeclampsia can be a risk enhancer. Laboratory measurements can be useful, like inflammation, lipoprotein little a, ApoB. These are more advanced markers that we can measure. And then lastly, another factor that we can consider is what's called subclinical atherosclerosis. So plaque deposition, when it happens, it can accumulate over time. We can actually measure that plaque deposition in the arteries of the heart using what's called a coronary artery calcium score scan, which measures the amount of calcified plaque in one's coronary arteries or heart arteries. And the higher the score, the higher someone's risk of having future heart disease or stroke. So if a patient otherwise maybe lower risk by risk calculators, but they end up having a lot of this calcified plaque, it's also a decision to start someone on a statin or other cholesterol medication. So anything more than zero, I think, is a reason that favors statin therapy. More than 100 and more than 400, studies have shown that patients with those high calcium scores have event rates that approach what's called secondary prevention. So they have event rates similar to patients who've already had a heart disease and stroke. So I would be very forthcoming with the patient about their risk and start them on statin therapy and controlling the other risk factors, of course, on top.